Welcome all. Please mute yourself, but always show your video picture. Sign in your name, Facebook account, or email address in the chat box. Please include names of the companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group picture taking at the start and at the end of the pep talk. So please show your face in the video during the picture taking. As a reminder, please take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. The link has been placed in the chat box by Ms. Beto Tumambing. Okay. Below is the picture of the certificate that will be issued to you once you pass the OLETE. Also, as a reminder, getting 50 OLETE certificates, okay, will entitle you to 1 voucher for free telemedical consultation. So let's now have a group picture taking before we start the pep talk proper in 2 minutes. Please turn on your video and show your face. Okay, 1, 1, 2. Okay, everybody ready? Okay. I cannot wait anymore. 1, 2, 3. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. October 23, 2021 onwards, I've been tackling health disorder and health issue courses. So this may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in Medical Management of Breast Cancer, Part 2. This is the part of the cancer course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of breast cancer. Let's have some definition of terms in the title and the limitation of the coverage of my talk. When I say fundamental, this will be used to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced and more information in the future. Generalities mean general statements of information, not covering specifics and not too detailed. Medical management, specifically on breast cancer, will be diagnosis and treatment of breast cancer, usually done by physicians. I have discussed part 1 last week, and now we are on part 2, okay, which will include the following: treatment, surveillance, prognosis, palliative, and hospice care for breast cancer patients. Let's start with treatment for breast cancer. After formulating the pre-treatment diagnosis, including determining the extent of breast cancer and other factors with effect on the treatment, the first thing to do, to be done by the physician, before considering and comparing the options of treatment methods or modalities is to spell out the specific objective or the goal of the treatment, whether curative or palliative. Curative goal means eradicating known tumors and cancers entirely, completely, preventing the recurrence or the spread of the primary cancer. Whereas palliative goal means relieving symptoms if all or after all reasonable curative approaches have been exhausted. As at the time of the treatment, a patient may present in a cancer stage in which the goal is at best palliative only, relieving symptoms. So these are usually patients with advanced, very advanced cancers. For patients presenting with early stage cancers, the goal is curative. It should be curative, that is eradicating the cancer entirely and trying to prevent recurrence or spread of the primary cancer. Thus, the objective of treatment is primarily dependent on the stage or extent of the cancer at the time of treatment. Staging and stage of cancers. Okay, this just means describing the extent of a cancer. Okay, there are so many ways of staging cancers. The simplest is to classify it into early stage and advanced stage. Another classification will be localized, regional, and distant. The other one is localized, early locally advanced, late locally advanced, and metastasized. And then the TNM staging, which describe the size of the cancer and how far it has grown. At the moment, in the medical world, this is the most popular, okay, the TNM staging. Okay, T stands for tumor, N stands for nodes, and then M stands for metastasis. When you have stage 1, the tumor is localized, limited, okay, no nodes yet, no distant spread. When you have stage 4, it has already spread to distant organs like the brain, the lungs, and the bone. Okay. In between stage 1 and stage 4 are stage 2 and 3. Okay. There are, at the moment, for breast cancer, probably in some other cancer, it will also follow, but at the moment, it has included the prognostic staging aside from the anatomic staging. The minimum, the very least in the staging system is that it should have the anatomic staging. Okay. So lately, with the advanced technology, we have come out with prognostic staging. So anatomic staging means this is defined by areas of the body where the breast cancer is found. Okay, just like the TNM. Okay, prognostic staging is how likely a patient is to be cured of cancer, assuming that all the appropriate treatment, is given. So this is a illustration of the anatomic staging for breast cancer. Okay, stage 0, 1, 2A, 2B, 3, 3A, 3B, and then 4. As I said, once you have M, it's already stage 4. So in breast cancer, the more common sites of metastasis are the bones, lungs, liver, and brain. Okay, if you have stage 0, it means it's still localized to the milk ducts. No, and the other term is ductal carcinoma in situ. Okay, for stage 1, usually there's only one T and smaller. There's the T which is smaller than 2 cm, and then there's no nodes, no distant metastases. Okay, for T stage 2A and 2B, the difference is that the size, mainly the size. Okay. Okay. Plus the lymph nodes. The presence of lymph nodes automatically makes it stage 2, but the size can vary. Okay, but usually it's less than 5 centimeters. Okay, now stage 3 are the so-called locally advanced breast cancer. An illustration of the prognostic staging system for breast cancer, which is commonly used nowadays. No, this make use of the information that are gotten from the receptor assays and HER2, okay, which can predict prognosis. Okay, ERA means estrogen receptor assay, PRA progesterone receptor assay, HER2 is human epidermal growth factor receptor A. So based on the examination of the tumor, if it's there's one category of staging here in terms of prognosis: ERA positive, PRA positive, HER2 new negative. This carries the best prognosis if you have this information on the tumor. Okay. Now, if you have ERA negative, ERH2 negative, this is what is called triple negative. This has the poorest prognosis among the four groups. There are a lot of cancer treatment being advocated, mainstream ones and non-mainstream ones. Mainstream ones are those accepted and being promoted by majority of the physician cancer specialists. That's why it's also called conventional or standards. And it has well-documented evidences of effectiveness, although in varying degrees, not always 100%. Non-mainstream ones, meaning non-mainstream just mean outside the mainstream ones, or the so-called alternative medicine. And then the health claims here are not usually meeting the evidence-based standards. The mainstream modalities of treatment for breast cancer are the following: surgery, okay, meaning operation. Okay, essentially the process is cutting; radiotherapy, making use of radiation, burning the tumor; chemotherapy, using drugs to kill the cancer cells; hormonal therapy, hormonal manipulations; immunotherapy, immune system manipulation; and targeted therapy, gene manipulation. The alternative medicine is defined loosely as a set of products, practices, and theories that are believed or perceived by the users to have healing effects of the medicine, but whose effectiveness has not been established using scientific methods. That's why it's still called alternative medicine. The commonly used non-mainstream or alternative medicine treatment for cancers are the following: herbs and herbal medicine, special diet, supplements including vitamins, high dosage of vitamins, acupuncture, lifestyle medicine without the use of drugs, but relying on healthy living, healthy eating, physical activity, and other healthy behaviors. Words of caution on alternative medicine for breast cancer or other cancers for that matter: delaying surgery, radiation, chemotherapy, and other traditional treatment by using an alternative therapy can allow the cancer to grow and spread to other parts of the body. And evidence have shown that people who use alternative therapies in place of standard cancer treatment have higher death rates. In a study, a 2017 study, and there are more studies coming up, after a median of 5 years follow-up, patients with breast or colorectal cancer were nearly 5 times as likely to die if they had used an alternative therapy as their initial treatment than if they have received conventional treatment. The mainstream modalities of treatment for breast cancer can also be classified into localized and systemic. Localized treatment means that the treatment are directed to the local area or specific limited area, such as the breast and armpit. So example of localized therapy will be surgery and radiotherapy. Systemic therapy are those using drugs and other chemicals that spread throughout the body to treat breast cancer cells wherever they may be. So this include chemotherapy, hormonal therapy, targeted therapy, and immunotherapy. The breast cancer treatment may be single or combined modalities depending on the extent and track records of effectiveness. So one may use localized therapy alone if the tumor is really small and localized. Example of localized therapy would be surgery or radiotherapy. If it's widespread already, and then the tumor cannot be operated on or cannot be radiated anymore, then systemic therapy is used. But if the tumor can still be operated on, you can do the localized therapy, either radiotherapy or surgery, plus the systemic treatment. Okay, so examples of combinations of treatment here will be surgery first, then followed by chemo, followed by radiation. Another regimen will be chemo first, then surgery, then chemo, then radiation. Or another combination will be surgery first, followed by hormonal therapy. Any cancer treatment can be used as the primary treatment, but the most common primary cancer treatment for breast cancer is still surgery, especially those in the operable stage. Other combinations of treatment are done depending on the anatomic stage, prognostic stage, and other factors like track records of effectiveness. There are many types of operations: radiotherapy, chemotherapy, hormonal therapy, and other types of therapies. So for the operations, you have these options depending on the extent, depending on the decision of the surgeon and the physician and the patients. Total mastectomy, subtotal mastectomy, not including, not removing all the parts of the breast, axillary dissection, and axillary sampling. Examples of radiotherapeutic regimens will be external beam radiation therapy and brachytherapy. For chemotherapy, it can be used singly or multiple. Most of the time, it's multiple, meaning in combination. So you have different combination like CMF, CAF, and taxane and docetaxel. Okay, CMF, its letter here represent the first letter of the drugs, cyclophosphamide, methotrexate, 5-FU. Okay, hormonal therapy can include the following: tamoxifen, letrozole, anastrozole, exemestane, and then other therapies like trastuzumab and fulvestrant. After the physician has decided on the goal of the treatment, he gives or lists the various options of treatment and then gives data on the BRCA, okay, benefit, risk, cost, availability. With the data given, the patient is asked what or she prefers. Example of BRCA comparative analysis of treatment procedures. Option 1 has the greatest survival rate compared to option 3, which has the least survival, and then option 2 in between. Okay. Assuming that the risks are all acceptable to the patient and can be tolerated, and then the cost is 5,000 for option 1, 6,000 for option 2, 3,000 for option 3. And assuming that all are readily available, so the best option here will be giving priority to the goal of the treatment, which is the benefit, greatest survival rate. So the best will be option 1. Okay, and then the cost is acceptable at 5,000. Surveillance of breast cancer, the next topic. Surveillance just means monitoring for 1, recurrence after all evident cancers are eradicated, okay, what is called curative treatment, and monitoring for progression or regression after palliative treatment if the curative treatment cannot be done. Okay. The common issues or questions being asked: by whom, how long, how often, what methods. By whom? Usually the oncologist, okay, and some can put in the family physician to help them. Okay, so the criteria to choose will be competence, whom you prefer, meaning preference by the patient. Okay. The basis will be the following: competence of the oncologist or the physician, expertise, professionalism, holistic and compassionate care, cost, okay, the professional fee, availability, and convenience of consulting him or her, etc. When you say oncologists, these are doctors with specialty in cancer management. There are various types. There's no such thing as only one type of oncologist. The surgical oncologists are those surgeons who specialize in treatment of cancers. Medical oncologists are those physicians, usually internists, who specialize in the management of cancer, usually giving drugs. Okay, this surgeon usually operation. Radiation oncologists are those which specializes in giving radiation to cancer patients. Okay, there are others. Others could be, okay, there's such thing as pediatric oncologists, gynecologic oncologists, and hematologists, etc. Okay. So one may choose one or more as indicated and as preferred. You can choose one to orchestrate everything, okay? And then when you choose one or two, okay, you use this basis as for your selection, for your decision making. How long should the surveillance be? Okay. For those with curative treatment goal, it's a lifetime, okay, surveillance, as all cancers have the potential to recur even after a long period of time of remission, okay, even after 10, 15, 20 years. And then for those with palliative treatment goal, there are three scenarios here: until signs of progression and regression occur, until a call or a decision is made for hospice care to be made already, okay, no more aggressive treatment, and then you can monitor it up to the end of life. How often? Two situations: monitoring for immediate results of treatment and monitoring for recurrence after curative treatment. For monitoring for the results of treatment, usually the monitoring is done for the side effects and complications of treatment, like surgery, the complications of surgery right after the operation, complications of chemotherapy and radiation. And then the other thing to monitor is the response to treatment, okay? Particularly for chemotherapy and radiotherapy, to see if the tumor is shrinking or not. The duration of monitoring will be dependent on the type and duration of the treatment, okay, whether it's surgery, chemotherapy, radiotherapy. The recuperation time, expected response time, such as 2 to 3 months after chemotherapy, etc. And the frequency as to how often, so it depends, but it ranges from daily to every month, with an average of 6 months or even longer, as indicated. For the monitoring of recurrence of cancer after a curative treatment, it depends on the type of the cancer, treatment done, usual prognosis, time of treatment, whether the surveillance is at a time that it's soon after the treatment or long after the treatment, and then also the mindset and personality of the patients, etc. As a general guideline, the monitoring for recurrence after curative treatment for cancer will be more often for those with higher risk for recurrence, such as if the cancer is of the aggressive type, so you expect a high risk for recurrence soon enough, quite soon, then more often will be the monitoring frequency. And then if it's early post-treatment, say 1 to 2 years, when recurrence usually appears. Majority of recurrence for cancer after treatment usually appears within the first 2 years, okay, or even some within the first 5 years. Okay. And then the other factor to consider, the guideline would be anxious patients who need frequent psychological support from physicians. If this be the setting, then the monitoring will be more often to take care of the psychological support care of the patients. What methods? Two methods: symptom sign directed surveillance approach and regular screening with the battery of tests approach. When you say symptom sign directed surveillance approach, it means that the patient's symptoms, what she feels, and then the physician signs what the findings of the physician on physical exam. All the both will direct or will dictate what instrumental laboratory test will have to be done. Okay, so it's not an outright doing instrumental laboratory tests right away. And then the regular screening instrumental laboratory diagnostic test directed surveillance approach. This means there's a battery of screening tests on the possible sites of recurrence. Okay, so these are done even in the absence of symptoms and signs. The physician gives or lists the options of surveillance. Okay, basically two: symptom directed, battery of test directed, and then gives the data on the BRCA again. So with the data given, the patient is asked what or she prefers. Okay. So when you talk about surveillance for breast cancer, then comparing these two methods, for the benefit, you have to take note of these three factors. Okay. In terms of early detection, which has the better advantage; in terms of survival, which has the better advantage or the same; in terms of quality of life, which has the better advantage. So example of information data that are being published, okay, on the two methods of surveillance: symptom directed and symptom sign directed and battery of test directed. Okay. So for the option one, between option one and option two, in terms of early detection, of course, when you do a battery test, you tend to find a lot of things. So it has the better advantage of detecting cancer earlier. Okay. Now for the survival, how long they will survive for option one and two, studies have shown that survival rates are the same. This is for breast cancer. Huh? Okay. And then for quality of life, okay, which one is better? It's said that option one is better compared to option two. Okay. Although the option two will have earlier detection, okay, but the patient is suffering for a long time because they die at the same time. Okay, so that is what it's meant by poorer quality of life for the second option, which is the battery of tests. Okay, so because of a lot of tests, there's a high risk for false positive results in the laboratory tests. And then, of course, in terms of cost, because of the battery of tests, this one, the battery of tests directed surveillance, has the highest or higher cost. Okay. Prognosis of breast cancer. Prognosis just means the estimate on how cancer will go for you, for each of the cancer patients. It means the likely course of cancer without treatment, and if with treatment, whether curative or palliative, what is the likely outcome, and what are the chances of recovery? That's another way of looking at it. What are the chances of response to treatment? Okay, either cure or recurrence, and then making use of the 5 to 10 year survival rate data and the median survival rate data. In general, the prognosis of breast cancer is dependent on the type. Example, sarcoma. Breast sarcomas have poorer prognosis than adenocarcinoma. Stage of cancer, stage 4 has the poorest prognosis. Inherent biologic behavior of the cancer, with or without comorbidities on the patients, which might affect the treatment, and also the gravity of these comorbidities. And then, of course, the track records based on data available of the cancer. Okay. So usually in the medical world, we usually use 5 to 10 year survival rates and also the median survival time of the different cancers. Okay, and then this can be data can be segregated into by stage of the cancer. What is, let's say, stage 1, what is the 5 year survival rate? Stage 2, what is the 5 year survival rate, etc. And then with or without treatment. Again, what is the 5-year survival rate with treatment? What is the 5-year or 10-year survival rate without treatment? When you say 5 to 10-year survival rates of cancer, it just means the percentage of cancer patients who are still alive 5 years or 10 years after they were diagnosed or treated. So this is an example of the 5-year breast cancer survival rate. Okay, so this may change over time, but practically it has been there for quite some time. Okay, so stage 0, close to 100%. When I say close, it's not always 100, it's probably 99. Okay, and then stage 1, 98% at 5 years. Stage 2, 5-year survival rate is 93, lower already. Okay, and then stage 3, 72%, and then stage 4, 22%. So this table shows the data that's gotten for 5-year, 10-year, and 15 years. Okay. The median survival of cancers means the length of time from either the date of diagnosis or the start of treatment for a cancer that 50% or half of the patient diagnosed with the cancers are still alive. Okay. They usually measure this in terms of months, but sometimes it can be measured in terms of years. Okay. So the median survival time can be calculated based on with treatment or without treatment, and also based on the stage and based on the types of metastases. So let's say stage 4 breast cancer. Okay. So the 5-year survival rate is about 20%. Okay. In that table that I gave is 22%. Okay. Then you input the put in the median survival rate. Let's say the data is about 3 years. So you now have information on the prognosis of a stage 4 cancer. Okay. So in terms of survival rate when there is already metastasis. So an example here, okay, for patients with brain metastasis, the median survival rate is 8 months. Okay. And then for those with bone metastasis, longer, 36 months. Okay, so it all depends on the site of metastasis. Now, if there's only one, okay, but usually it can be multiple, meaning liver and also including the lungs. Okay, so I got hold of this article now just to show you that nothing absolute in the prognosis or even medicine. There are exceptions to the rule. Okay. So here is a patient who has survived for a long time, even with metastatic breast cancer. Okay. So we mentioned about the stage 4 survival rate is 22, 5-year survival is 20%, and then the median survival is about 3 years. Okay. So here, a 2-time cancer survival became the oldest living American. Okay. She turned 144 years old in October. This is this year. This is 2021. She now holds the records of the oldest living American, as the previous record holder died recently at age 116. Okay, she survived breast cancer twice during her lifetime. But this just goes to show that there are exceptions because to the rule, to the statistics. No? Last topic would be palliative and hospice care for breast cancer patients. 2 terms that one can encounter in the medical management, which most Filipino lay people are not familiar with, and which most doctors do not acquaint their patients with. So the 2 terms are palliative care and hospice care. Palliative and hospice care are being used in patients with advanced cancer patients, any type of cancer patients who have little or no prospect for cure and who are expected to die, and for whom the primary goal is just to optimize the quality of the remaining life on Earth. Both palliative and hospice care provide comfort. Okay, they have something in common. Okay, in terms of physical, mental, and spiritual comfort. Okay, the difference between palliative and hospice care is that palliative care starts first. It can begin at the diagnosis and at the same time as the treatment, and it can consist of anti-cancer treatment. Okay, the the active anti-cancer treatment. Okay. Hospice care begins after treatment of the cancer is stopped. Okay. So let's say somebody declared that no more anti-cancer treatment because it is quite evident, although not 100% sure, 99% probably the person is not going to survive the cancer, then there's a call for hospice care already. Okay. So here, this illustration shows start with advanced cancer. Okay, so with advanced cancer, you don't have curative goal, you just have palliative goal. Then you start with palliative care, still with using anti-cancer drugs, hoping for a resolution or improvement. And then if the anti-cancer, the palliative care is not effective anymore, then you can call for a hospice care in which there's no more anti-cancer treatment, just go by the natural means, natural methods of treatment. So summary and takeaway, I have discussed the part 2 in these sessions, which include the following: treatment, surveillance, prognosis, and palliative and hospice care for breast cancer patients. Takeaway in relation to patient empowerment: be always in touch with reliable medical information on fundamentals and generalities in medical management of breast cancer. As we all know, knowledge is power and it gives power. Please use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of breast cancer. So with that, I end my PEP talk, Fundamentals and Generalities in Medical Management of Breast Cancer, Part 2. I hope I have enlightened you, okay, to have a better understanding of the fundamentals and generalities in the medical management of breast cancer. So before we go to the question and answer session, please, as a reminder, please take the online Learning Cube Evaluation Test exercise for mastery of learning and have a perfect score to get a certificate. Okay. I've seen the link placed in the chat box already by Ms. Beth Tamambing. Okay. And then again, reminder, try to get 50 Alete certificates if you want to have a voucher for a free ROJoson telemedical consultations. Okay. So with that, let's now have a group picture taking before we have the question and answer sessions. Okay. Show your face. Evelyn, Abigail, Angie, Aida. Okay. Ready? Marianne, you don't like to show your face? Aida, I guess. 1, 2, 1, 2, 3. Okay, I think we only have one page. Okay. The floor is now open to questions, comments, suggestions, and anything that you want to share with us. Okay. Anything? So this is actually the third session on breast cancer. We started with breast cancer development and then 2 sessions on the medical management. As I said, I just gave you the fundamentals and generalities. No? Okay. So during the open forum, you can ask more questions, detailed questions. No? Okay. And I think I spent about 30 minutes, a little more than 30 minutes in giving you the lecture for today. I just hope it's not very taxing for you as a patient, as a lay people. Okay. Anybody who wants to share their, I think a lot of you are breast cancer patients here. No? Does it ring a bell? Do you recall what you went through? Okay. Anybody? Anybody wants to share or ask questions?
Doc.
Yeah. Okay, Radies.
When you say modified radical mastectomy, it also refers to total mastectomy. Are
Yes.
they one and the same?
Yeah. Not totally one and the same. Okay. When you say how do you say that? Radical. Okay, the term
Modified.
there are two. Okay, we start with modified radical mastectomy. Okay, that's a commonly used term. Okay, but before that, because of the word, you notice there's the word modified. No, so it assumes it's assumed that there's a modification that happens from with an original operation. Okay, there's a modification. So the first type of operation is the so-called classical. Okay, kaya naging modified. Classical, no, the first one, classical radical mastectomy. Okay, then as time goes on, they've shown that there's really no need to do classical radical mastectomy in all cancer patients. So they now make it modified. Okay, they modify it. So that's why it's called modified radical mastectomy. The first one is classical radical mastectomy. Okay. Okay. Let's now look at the components of the procedure. Okay. The components of the procedure is that in the classical radical mastectomy, you have total mastectomy plus axillary, yung armpit dissection. Okay. Both. No? And the third one is removal of the muscle on the chest. Okay, that's a classical. So three components there. Total mastectomy, removal of the entire breast. Number two is removal of the entire breast, including the muscle. The muscle where the breast is lying. Okay, and then armpit dissection. Okay, three components. Now modification just means, okay, what is modified here is that you don't have to remove the muscle. Okay. Okay. So modified radical mastectomy is just total mastectomy plus armpit or what we call axillary dissection. So, okay, so the muscles are retained, are not removed. Okay. So, but there are,
thank you, Doc.
Although it's very popular is the modified now, it doesn't mean that you should not do classical. If there are instances in which the mass is too big, it has invaded the muscle, no, then we still do classical. So it all depends on the extent of the tumor. Okay. Fortunately, a lot of times, I hope it will be the trend now. Fortunately, a lot of times when we see patients, the tumor has not invaded the muscle. So that's why we do the modified radical mastectomy. Okay. Okay. Did that answer?
Thank you, Doc. Thank you very much.
Okay. Okay. Any questions, Abet? Okay, Doc. In what test makikita yung mga ERA, PRA, HER2 new? Okay. So in what test? Okay. First of all, this is a question by Jocelyn T. Okay. So you get a sample of the tumor of the breast cancer. Okay. It has to be a big sample, not just the hypodermic needle, yung ina-aspirate lang, no? Okay. It has to be a bigger sample, and then they examine it for the ERA, PRA, HER2/neu, and other tests. Okay. Okay. So it can be done right after the operation also, when the whole mass is removed, then you can have it done. But before the operation, if you get a sample, make sure that it's big enough to enable the test to be done, the ERA, because there's a requirement of the size of the sample. No? Okay. Before the operation, the surgeon can use the core needle. When you say core needle, it gets a bigger sample size compared to yung hypodermic, yung ordinary syringe. The ordinary syringe can also make a diagnosis that it's cancer or not. No? Okay, but if you really want to study the tumor further in terms of ERA, PRA, you have to use a core needle, minimum core needle. Okay, if you don't have a core needle, then the doctor will use a section, remove the entire breast and the mass, or just wait for after the operation. The test can be done after the operation. Okay.
At the rights, can you read the question? Hindi ko masyadong mabasa. From Angelina
okay,
Presa.
from Angelina Presa. Doc, tanong ko po sa inyo, ang isa po na inoperahan sa breast. Di daw po niya kailangang mag-chemo at radiation. Meron po bang ganon? Stage 3 po siya. Di rin po mag-chemo, sabi ng doktor.
Okay. Number one, okay. Two things here now. Number one, sino yung doktor? Okay. Kasi some doctors are just like the vaccination, di ba? Issue. There are some doctors who don't believe in vaccination. There are some doctors who believe in vaccination. Okay. So there might be some doctors, especially those in practicing alternative medicine, okay, who don't believe in the mainstream line of treatment like chemotherapy. Baka sabihin niya, hindi ba kailangan, hindi ba kailangan. Okay? So it all depends na kung sinong doctor ang kausap mo. Na? Okay? Number two, if you go by the mainstream treatment, no, the things that the conventional one, okay, the conventional one, okay. So when you have stage 3, that means you have a bigger size tumor, and then you have most likely you have an N positive, but just you don't have the M. Okay, wala pang distant mets. Okay, so this is quite advanced already. Okay, so usually when you have the N positive already, and then the tumor size is quite big, then there's a bigger chance that it might have spread already silently to the distant organs. It's just that it's not being felt, it's not being seen at the moment. Even with all the imaging tests that you will do, kahit na sinabing negative, no? Kahit na yung pinakamahal na test that you might want to do, okay, like the PET scan, pag sinabing negative, it's no guarantee that it's 100% negative. Okay, there's still a big chance that it's there. Okay, I'm not saying it's 100% there. Okay, but bigger chance that it's there. Okay, so if you really want to run after those silent metastases, no, then the thing to do now is to give chemo, or other systemic therapy. Okay, so it doesn't have to be chemo per se. You can use other systemic therapy like hormonal therapy and other gene therapy. Okay. Did I answer your question? Okay. The other factor probably you have to consider is baka ayaw ng pasyente magpa-chemo. No? Okay. So we have to respect that. No? Okay. So anymore.
Doc, merong isang
Did I
Meron
answer? Sandali. Did I answer Angie's properly? Angie? Walang sagot. Oh, sige.
Angie,
Go ahead. Sige, go ahead na lang.
meron pong isang tanong from Maria Justa Polotan. Good afternoon, Doc Joson. Is surgery an option in inflammatory breast cancer if it is diagnosed in its early stages? Thank you.
Yes, Maria. Theoretically, yes. Theoretically. Okay. Okay. So, pero number one, usually when you have inflammatory cancer, no? Okay. Usually, malaki na yan eh. Advanced na yan eh. No? Okay. So you're saying if it's diagnosed in its early stage, that's why I said theoretically it can. No? Okay. But if it's the usual run-of-the-mill inflammatory breast cancer, usually malaki yon. No? Okay. But, okay. The other thing that we have to differentiate is kami mga specialists, we have to, in our practice, sometimes inflammatory breast cancer is mistakenly diagnosed. Okay. You might have the so-called invasive ductal carcinoma, not the special type like inflammatory carcinoma, which nag-ruptured lang siya ng konti, no? Okay, pumutok sa skin at nagkaroon ng infection, no? Inflammation, okay? And then sometimes mga doctors, no? Surgeons, they label it already as inflammatory breast carcinoma, okay? So that's a special type, no? It has to be confirmed by a histopath biopsy, no? To make sure that it's really inflammatory breast cancer, no? Okay. So yung mga pumuputok lang at may inflammation, no, we don't call that inflammatory breast cancer. Okay. Yun mga ganon, pwede pang operahan. Okay? So it's under the adenocarcinoma, invasive ductal carcinoma group. Okay? So medyo technical lang ito, but I'm just trying to clarify your questions now. Okay.
Okay, another question from Jocelyn T. Is the ERA asan na ba? Is the ERA PRA test automatically done by the surgeon?
Nowadays, yes, but as I said, there are exceptions to the rule. Okay. Okay. It's not only ERA, PRA. They always, at the moment, today, nag-evolve kasi yung mga ano natin, yung mga practices. No? So it's 10, 20 years ago, probably walang ERA, PRA. Now, pumasok yung ERA, PRA. So a lot of surgeons are doing it. Then after, for the past 5 years, pumasok yung HER2/neu. Okay? So ginagawa na rin, di ba? And then, for the past 2 to 3 years, may KI something, 19, ginagawa na rin. Parang ano yan, dekahon na yan. No? Okay. So it all depends on the surgeons, the mindset of the surgeon. You mentioned about the surgeon, what he thinks. Now, if he is the so-called ritualistic, maximalist surgeon, he will do everything. Okay. If he is a minimalist surgeon, minimalist meaning doing only what is needed, no? And then of course consulting the patient what he wants, then he doesn't have to do all automatic. No?
Thank you.
Example, sometimes I don't do this HER2/neu anymore because I will ask the patient if it's positive, are you willing to undergo trastuzumab, now, which will cost you more than 1 million pesos? Are you willing to do that? Are you willing to spend? Now, can you afford it? If he said he cannot afford it, so why go for the test pa, di ba? Okay, so you can just compromise and just do a little ERA, PRA, So you can afford tamoxifen, baka tamoxifen na lang. It's only 19 pesos, 17 pesos. No? Ganon. So it all depends. No? Okay. So here comes yung mga interplay of the so-called the doctors playing a role. Okay. Basta may informed decision also. But for the doctor side, you have to differentiate ritualistic, yung dekahon, who just follow the fad. No? And then maximalist, they do everything, all possible. No? Okay. And then the minimalist surgeon. No? Okay.
Thank you, Doc.
You're welcome.
Okay, another question from Bellet del Rosario. Doc, what does it mean when the diagnosis is invasive mammary carcinoma of no special type? Nothing, ano ito? Histologic grade 2.
Okay.
Background of ductal carcinoma in situ, cribriform pattern, nuclear grade 2. Medyo technical po.
Okay. 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 I can understand you're trying to learn to try to interpret the pathologist report. No? Okay. Yung pathologist report, marami silang mga terms na ginagamit na you don't understand. Okay. And then even the doctors sometimes they cannot understand, the clinicians do not understand because nag-evolve kasi in medicine, no? Okay. And then so once pathologists learn new things, they use it already, no? And then yung mga clinicians are not up to date, no? Habol sila. Ano ba ibig sabihin nito? Okay? Anyway, that's good. That's a good attempt to know what these are from a layman's point of view. No, medyo mahirap lang, ha. So you just have to ask your doctor to explain it to you. Example, okay. First the type, no. Yung type muna, ha. And then kasi you have the grade, no. Okay. Yung type, dati-dati yan, we call that invasive ductal carcinoma. Okay. So during the past 2 years, naging ano na yan. They call it mammary carcinoma. They don't like to commit themselves to. As in my first session, I think I classify breast cancer into ductal and lobular, di ba? Okay, that arising from the duct, the one arising from the lobules, no? So yung pinaka-common is ductal carcinoma. Okay, that's why the previous term is invasive ductal carcinoma. Yan ang pinaka-common, no? Pero nowadays, they use the word mammary. Okay? Okay. For me, I just consider them as the same. Kasi sa akin, kahit na may mga new changes, but basically the treatment will be the same, no? Okay. So it's not okay in terms of type. It's not the sarcoma, okay, at least, okay. So it's the adenocarcinoma type. Now it's invasive. Now it's meaning it's a little advanced. It has gone out of the cell. Okay. Okay. Nakikita mo yung background of ductal carcinoma in situ in your question. Okay. The ductal carcinoma in situ in that question that you posed. No. Okay. Ductal carcinoma in situ, it's still inside, no? Okay, not outside the cells. Okay, so when you say invasive, it's already outside. Okay, so there's a combined findings of ductal carcinoma in situ and also the invasive type. Okay, and then as to the nuclear grading, okay, so you have 1, 2, 3. Okay, so yung pinakamaganda. Tinatawag na pinakamaganda, well-differentiated grade 1, then grade 2, grade 3. No? So titingnan nila yung cells kung gano'ng ka-similar dun sa mga normal-looking cells. Kung masyadong kaiba, no, bizarre na, okay, malayo na, they call it grade 3. No? Okay. So, minsan meron pa isa, undifferentiated. Hindi nila talagang ma-explain kung anong category na. No? Okay. But usually majority will be grade 2. No? Okay. Okay?
Okay, Doc. There are 2 last questions. Sabi ni Miles Ocampo, Doc, may mass po ako na minsan nasa ilalim ng nipple. minsan sa right side at minsan sa ibabaw ng nipple sa left breast. Is this a symptom of cancer? Kasi it seems it is not fixed, pero parang lumalaki po.
Okay. Malaki. Okay. Ang ano, okay, I guess the best thing would be to have a consult. No? Okay. You can have me to you can consult me or you can consult any other kasi kung sinasabi mo lang sa akin nawawala nung andyan, most likely walang problema. Pero kung sinasabi mo lumalaki, no? Ayan, that's alarming na 'yon, ha? Kung lumalaki, no? So I advise that you have a consult first, no? Wag mo nang mammography ultrasound, ha? Okay.
Opo. Thank you.
Doktor muna, examinin mo na, ha? Baka baka normal pa rin 'yan, baka mali lang yung interpretation mo of your findings, nang ganon. Na? Okay?
Thank you po, Doc.
For Evelyn, from Evelyn Yu, is it okay for a 80 plus years old who has metastatic breast cancer to undergo chemotherapy?
Okay. It all depends. It all depends. But as a general rule, okay, number one, it depends where the breast metastasis is. Now, if it's on the bone, is it on the liver, the brain, or the lungs? Okay, those are the most common site. Would you like to answer that before so that I can amplify my my answer to you? It all depends, na? Evelyn? You want to pursue that or general answers na lang muna?
I think sa bone siya eh.
Okay. Okay, kung sa bone, okay. Masakit na masakit. Kung bone lang, no, pwede pa. And then the other factors that you have to consider whether she's a strong 80, ibig sabihin, malakas pa siya, she might survive for another 5-10 years, no? So you can opt for a chemotherapy, no? Okay, but there are other options, huh? Not only chemotherapy, you can also have hormonal therapy. Okay, so that's why yung sa BRCA ko, yung sa options, you have to list down for bone mets, you can have the options of chemo, then hormonal therapy, no? Okay, dalawa muna, no? So baka kung ERA positive siya dati, no, baka you can try hormonal therapy first. Kasi mas maraming side effects yung chemo, no? Okay.
Okay. Thank you.
Okay. So two factors were the metastasis and then how strong and then what is the projected parang actual studies is strong enough to live for another 5-10 years, no? Okay.
Thank you.
Okay.
Okay.
Thank you.
There is I think this is the last question in the chat box, Doc. Good afternoon, Doc. I have a palpable mass at my right lateral breast. Movable, slight pain upon palpation. I think it is 2 centimeters. I haven't consulted any doctor yet. What can you advise for me to do? What test should I take? Thank you. From Etelyn Santos.
Diba? Saan ba na-metastasize, mama mo?
Okay. Unmute pa kaya, unmute. Sige, unmute. Okay, so anyway, parang medical consultation nito. Okay. I have a palpable breast mass in my right lateral. How old are you? Etelyn Santos, how old are you? 2 cm? Okay.
53, Doc.
53. Okay, it's really a mass, dominant mass. Nakakapa mo talaga kasi kung minsan yung nakakapa mo, sabi mo mass, baka hindi na talaga bukol, no? Okay, that's one possibility, no? Okay.
Yes.
So ang suggestion ko is that you see a clinician mo na breast specialist before you think of the test. Okay? So that should be the approach for all patients, no? Wag kayo, don't jump into the ultrasound mammography right away. Have a consult first with a breast specialist. No? Okay. So ang tendency is for the Filipino peoples to, ay, papamammography and ultrasound lang ako. No? Okay, kagad. No? Okay.
Okay.
So
Thank you.
consult ka muna sa isang breast specialist. No? I'm not saying it should be me, but the breast specialist, basta yung surgeon. Ha? The breast specialist, kasi kailangan kapain yan. No? The breast specialist here is a surgeon because surgeons are adept in palpating. No? Okay. So it's not I'm trying to look down on the other doctors. No? Kasi a lot of times you also see medical oncologists, gynecologists. No? So they are not really well versed in palpating. No? It's a surgeon kasi kami, yung surgeons, kinakapa namin. No? Okay. And then we operate. No? Nalalaman namin kung ano yung tama, ano yung mali. Di ba? So we learn how to palpate. No? Okay. So the best palpator, breast palpator, I call it breast palpator, are the surgeons. No? Okay. Okay.
Okay, Doc. Thank you very much.
Doc, may isang pahabol na tanong from Aida Antonio. Doc, layman's term or Tagalog for palliative stage? Question mark. Is it okay to insist pa rin ng treatment?
Yeah, when you say palliative stage, saka yung treatment, you have to qualify. No? When you say palliative stage, you can still anti-cancer treatment as well as supportive treatment like pain relief. No? Mga pain relief. No? Okay, pwede pa yun. No? Now, kung nasa hospice care ka na, wala na yung anti-cancer treatment. You just give the supportive treatment. So treatment pa rin yun. No? Okay? Okay. So if there are no more questions, let's call it a day. But before we leave, okay, I want to ask you one thing. Thank you for all your questions now. Okay. Number one, you have seen my post. Andiyan si Chuchi pa. Chuchi.
Umalis na po siya, Doc.
Okay.
May
He has to leave. Ito na. He has to leave.
Yeah, I know. Okay. But I'd like to congratulate her personally. Yung last ulit niya, siya lang nakakakuha ng one try. At age 75, sabi nga niya noon, di ba? Sabi niya na, ay, hindi ko na kaya, matanda na ako at mga ulete, but she was very persistent and diligent. Okay, so I have to congratulate her. Na? Okay, but I also congratulate everybody. Na? Walang nag-give up. Everybody who took the 22 who took the test, pumasa. Na? Okay, yung iba kasi yung iba after one take kung di ma-perfect, wala na, di ba? So yung 22 and then there was another one talagang believe ako 10 tries. Okay. So the trick there is actually you take it one, usually pwedeng 2 to 3 lang pwede na. After the first try, kung may mali kayo, i-note down na ninyo kagad sa isang papel, whatever. Okay. So when you take it again, alam mo ninyo what is the correct answer.
Saan ka nagkamali?
Okay. So usually yung 2 tries, 3 tries, pwede na yan. Okay. Now the other thing that I like to so next week, okay, next week, we are supposed to have a Saturday session again, diba? Okay, so I have the topics in mind already. Now I'm still developing it. Now it's either health issue muna, health issue like breast self-examination, to do or not to do. Yon, yung health issue yon, di ba? Okay. I'm developing it now, no? Or I can jump to another cancer because a lot of you wants to talk about thyroid cancer already, di ba? Okay. I can jump to that, no? But there's another thing that's not bothering me, but I have to take into consideration. No? Okay. So we have a Cancer Crusaders Club meeting on Sunday. No? Okay. And my thinking is that I will not have the pep talk on Saturday in whatever topic it will be, no? Okay. But it will be done through the Cancer Crusaders meeting. So it will be a pep talk also. It will be part of the pep talk. The topic will be psychosocial management or support of cancer patients. Since we are in the as a cancer course naman tayo, di ba? So very timing naman di ba? So di ba? We talk about the cancer in general, then breast cancer, no? And then after this, i-amplify na natin iba, di ba? Yung mga issues, ganyan, no? So tamang-tama naman yung psychosocial therapy of cancer patients, di ba? So related siya, no? So related. So para hindi na kayo mag-attend ng twice o para hindi rin ako maghanda ng 2 days na lecture, gano'n. So I will just omit yung Saturday meeting natin, no? But do it on a Sunday, no? Okay. So the title of that pep talk will be psychosocial therapy of cancer patients in general, no? In general, no? Pero of course, the sessions will be not the usual lecture that I'm doing now. It's more practical now, more realistic now, because you're going to hear about 5 or 6 sharing of patients with cancer. Now, okay, magaganda ang sharing this year. Now, okay, video. Now, okay, so okay lang sa inyo. It will be medyo matagal lang, 2 hours. I hope I can finish in 2 hours kasi ang dami nag-submit ng sharing ngayon No? Okay, ang gaganda No? So then I will have also a lecturette on how to, on the psychological distress being experienced by Filipino cancer patients. No? Okay. So essentially yung session na yon, i-convert ko na lang into a pep talk. No? Ganon. Parang ganon. No? But instead of a Saturday, it will be on Sunday for next week. No? Para minsanan lang, no? And then we will just resume another topic the Saturday after that, no? What do you say to this proposal?
Okay lang po. So that would be December 5.
Yeah, 10 to 12. 10 to 12. Okay.
10 to 12. 10 to 12.
So please register. No? And then the Olete part, okay, sabi ko Olete rin yan. The Olete part, there's a quiz evaluation doon, kasama na doon. Okay? So may Olete rin yon, Olete part. No? But walang formal lecture like ganon, yung ginagawa ko ngayon. No? Okay? So now, if you cannot attend, okay rin, because we will show you the proceedings. No? You just take the quiz evaluation feedback form. No? So if you pass it, then you will get a certificate also of completion. No? Okay? Is that acceptable to all of you?
Yes, Doc.
Okay. So okay na tayo Sunday. No? Just for next week. Sunday 10 to 12. I will share with you the link later on. No? Okay?
Okay, Doc.
So if there are no more questions, let's call it a day. It's 3:15. Thank you for listening. Thank you for coming. Okay.